Hello, welcome to this NMC OSCE tutoring video. My name is Hannah. I'm an experienced UK nurse, a university lecturer, and have been an NMC programme lead. And I'm sharing with you some advice and teaching and information to help you self-study and hopefully pass your NMC OSCE. So I'm going to be doing some videos around the Child OSCE, and I wanted to start today looking at the Child Assessment Station. If you like my videos on my channel, please subscribe. It means so much. And please also share my videos with anyone you know that is studying for OSCE as well. That would be great. Okay, so I'm going to start looking at the Child Assessment Station. So assessment station's key part of your OSCE, and the same as all the other fields, you will have that 20 minutes to complete the assessment station. And remember, your assessment forms the first part of your API. So you've got your assessment, your planning, your implementation, and your evaluation stations, which make up 4 of the stations. And assessment is that first station. And you need to complete the holistic assessment with the child and the family, and also complete your A2 assessment, so the assessment of airway, breathing, circulation, disability, and exposure. And then children nurses, you need to complete the PEWS, so the Paediatric Early Warning System and Escalation Observation Charts. And I am going to plan to do a separate video looking at that in more depth, because that can be a little bit confusing if you haven't seen those charts before. And also, obviously, through your whole assessment station, your communication, your verbal and non-communication skills are being assessed. Your ability to, to communicate effectively with the child and also the parent or the relative and carer, and really demonstrating to the NMC those 6 C's of nursing, but also that you've got, your competence and your compassion and your clinical decision making. So key things that are particularly assessed in the assessment station is safety. So thinking about things, checking the scene, doing your patient and child ID checks, things like infection control, hand hygiene. Your observation skills, so you're going to be looking for any physical issues with your child, obviously doing a full range of assessment skills. Recognising any emotional or distress within the child and the parent, any social issues as well, any issues that might put that child at risk as well. Picking these up from the documentation and ensuring you address those in your holistic assessment. Like I said, communication is absolutely key. You'll need to demonstrate, correct ways to gain consent for your child and also with your parent, relative, carer. And documentation. So passing your assessment station is absolutely essential that you document your PEWS correctly and calculate your PEWS score correctly. And like I said, your assessment skills are going to be assessed. So being able to complete that A2 assessment correctly, using the correct technique for measuring your vital signs on a child. And again, obviously, you're going to have a potential range of ages for the child students, anything from newborn up to 15. So in Child, you just have 2 different assessment scenarios, so 2 different APIs which are currently being tested. So the first is asthma, and the second is a post-tonsillectomy bleed. So I'm going to do some further videos on these, looking at these API in depth. But in terms of your asthma, obviously with your asthma patient, there's going to be a presentation of difficulty in breathing, increased respiratory rate and work of breathing, wheeze, there could be some reduced saturations, and obviously anxiety and distress within the child and also the parent and carer. And the post-tonsillectomy bleed, normally, bleeds occur post-discharge, so the child has had their tonsillectomy and then re-presented back with bleeding. So your main assessment priority is obviously going to be that assessment of the risk of bleeding, how much has bleeding has occurred. There's obviously going to be pain for that child as well, so managing and assessing the pain. There's going to be risk of dehydration and potential risk of infection through where that tonsillectomy has occurred. So those are just some key things to think about in that assessment station if you get either of those 2 scenarios. And it is important to familiarise yourself with those main presentations. So if you haven't looked after a child with asthma or surgical post-op child for a while, it is good to read around those and identify the main nursing needs, as I've just very briefly explained. And this will really help you guide your approach and communication skills, but also guide your assessment. So you're making sure you're using your time wisely to really pick up on those relevant areas that need to be assessed. You'll have a mannequin for your child. So you'll have Sim Baby or Sim Junior, and you'll have an actor who will be present as your parent or carer. Depends on the how fancy the mannequins are at the test centres. You might have one which will breathe and have a pulse, and potentially make respiratory noises, or you might just have a standard mannequin, in which case you will go through the motions of taking your vital signs, but and doing your A2 assessment, but the examiner will feed you the information in terms of your results. But you will have an actor who will be the parent or the carer. So you're going to need to make sure you do correct communication, pick up on any relative or carer concerns. That is a scoring part on the PEWS chart as well. So really important you acknowledge and address any concerns of your parent or carer that is in the room with you. Like I said, communication skills are absolutely central, and the NMC are assessing you throughout your OSCE on your communication skills. Patient actors that are playing parents, they are very good. Be prepared for them maybe to be upset. They could be very anxious. They could be asking you lots of questions, and they might have specific issues that they want you to address. So don't ignore these. And specifically in relation to child, you want to think about how you're going to communicate and explain that procedure to the child, so the child understands it. So thinking about that child-centred communication skills, but also you'll need to explain it to the parent. You also need to really consider things such as play and distraction techniques. So finding out what the child likes, offering things that can be a distraction if you're doing a procedure or during your assessment. So things such as, toys, books, video games, TV. And also think about supportive holding and positioning, and where can you involve your parent actor into supporting that child during those procedures. The really specific child-centred techniques there. And part of that really is around family-centred care. So as children nurses, you should be really aware of the importance of family-centred care, and it's really the cornerstone of children's nursing, and it's recognising the family as central in that child's life. And it's about working in partnership with families. So it is really important in your assessment station that you are demonstrating family-centred care, that you're demonstrating, working in partnership with the parent actor, and also involving the child, the mannequin within your communication as well. And then consent. So in the UK, we have Gillick competency and Fraser guidelines. So again, just another area which is good to read up on. And these really, they came from legal cases from quite a while ago in the 1980s. But basically, they deemed that children, who have sufficient understanding and intelligence to enable them to understand what is involved, can also have capacity to give consent. So you can get consent from your child for your procedures, and you should do that. And as long as you feel that they are can understand sufficiently enough what the procedure involves and what you're going to do. But you should also seek consent from your parents or carer as well within that situation. So just a couple of things to look up on and be aware around consent in children. And it's also within the Children's Act in the UK, so this is legislation law, that children's wishes and views should always be taken into consideration for any decisions that affect them. So back to your kind of key assessment station information. So you'll be given your scenario, have key information on there about your patient. So presenting conditions, past medical history, social history, medications, allergies. That reading time is part of your 20 minutes, so you don't get extra time to read. It's really important to read that briefing information before you go in and start your official, interactions with your parent and child, so you know exactly what you're going into. Underline and identify key main priorities that you want to pick up. So again, in the presenting issues, but also in the social history as well. Again, looking out for any kind of signs of risk or any areas there that you need to be picking up on. Underline those or do whatever you want to those so it makes it clear. And use that information to support your holistic assessment. So steps to complete. So I always recommend having a clear breakdown of your assessment station so you know exactly what order you're going to approach the steps you need to do. So firstly, like I said, read your scenario carefully, highlight key areas of concerns and any problems. Start with your key principles, and I'll talk a little bit about what those are. Then I'd say move on to your A2 assessment, incorporate your vital signs within that, as we should be doing, and follow the marking criteria. Then I'd document your vital signs and on your PEWS, add up your score and verbalise your monitoring and any escalation. And it's good to secure that PEWS and get that done correctly before you move on to your holistic assessment, because the PEWS chart can feel a little bit complicated, and if you are rushed and trying to do it right at the end of the station, you're guaranteed to make an error, which will be a fail. And then once your PEWS is secure, use the rest of your station time to go on and complete the rest of your holistic assessment. And then finally finish your station. And if you've got any time left on the clock, always go back and double check that PEWS chart, make sure there's no errors and everything is complete. So starting your assessment station, so again, key principles, you want to watch out for safety, so you want to assess and make sure that it's safe to approach, that there's no hazards. Watch out for things that can be put around, things such as knives or food, water, maybe if the child's nil by mouth, or and ensure you address those. Then go on to your privacy and dignity, closing the doors or the curtains. You need to do your hand hygiene, following the World Health Organization 7 steps. Introduce yourself to the child and also the relative and parent. Find out who that adult is in the room and ask the child to confirm that they know who they are. And, it's just a safety thing there. So making sure you're talking to the right people. Check and ask for their preferred name. And then you just want to check their ID. So you can ask the child, again, it depends on their age, if they're verbal or not. So it depends what age your child is in your scenario, but ask them to tell you their name and their birthday. And you want to check that against your documentation and your wristband. And then just get the adult in the room to confirm that that is correct as well. And do the same thing with your allergies. And also check these against your name band and your documentation, and also get the adult to confirm. Explain what you're going to do, again thinking about how you're going to explain that to child, what types of things you're going to do during that A2 assessment, and gain consent from the child and the parent before you proceed. Check the child is comfortable, doesn't need anything, doesn't want anything to play with, any distraction techniques, and do a pain assessment as well before you start. And that's really good to do because you don't want to be doing anything on a child which is in pain or in distress. So you want to be managing that first. Then you're going to go on to your A2 assessment. So you should be really familiar with A2 assessment. Obviously, it's a key nursing skill and we use it throughout all our care settings. That systematic approach that recognises any areas which are outside of normal and any potential areas of deterioration, and then we treat those and then we move on. And it follows that systematic approach because it ensures all body systems are assessed in priority and nothing is missed. And you'll be familiar with airway, beta breathing, circulation, disability and exposure. Now, in terms of your NMC OSCE, the A2 assessment is identical to the adult A2 assessment marking criteria. However you feel about that. They don't employ anything like the paediatric warning assessment triangle, which you might be familiar with. It's purely just that A2E assessment, but you do also need to go on your intuition and your wider assessment skills as well, because on the PEWS, if you've got any clinical concerns, clinician concerns, then you can document that and that will escalate a trigger for you as well. So in terms of your A2 assessment for OSCE, just ensure you complete it in the right order, so A to E. Measure and take your vital signs following best practice guidelines for the child. Verbalise all your results and recognise when your observations are outside normal parameters, and the colour coding on the PEWS chart will help you do that. If you forget any part, obviously go back and verbalise to the examiner and get it completed. Like I said, you will have the sim baby or the sim child. So you'll be going through the motions within the mannequin and taking the observations from the mannequin. And I would just, before the start of this station, if the mannequin has got a pulse and is breathing, just ask the examiner to just help you locate those things. So you can get like an equipment checking before you start the station. So you can have up to 10 minutes, but the examiner can show you how to use any equipment in that station. So just be really clear about what the mannequin can and cannot do in terms of your assessment station. So as with all parts of your OSCE, you must verbalise everything during that assessment. Assume your examiner is blindfolded and can't see what you're doing and needs to follow along with your verbalisation. So make sure you're verbalising what you're observing and measuring your results, inform those to the child and the parent, and practice this as much as possible. It's a really key part to passing the station. I'm going to go very briefly through the A2 assessment. Like I said, this is the NMC marking criteria of what they want for the A2 assessment for the child. It's quite simplistic in terms of child assessment, but this is what is being asked. So A is obviously for your airway. So just confirm, if your child is talking to you, that you can confirm that the airway is clear, that there's no visual obstructions. So you could ask them to cough or open their mouth as well, and just confirm that the airway is clear. If your scenario involves an infant that's not talking, just verbalise, there's no signs of obstruction, no stridor, no croup, no foreign body, and you're happy that the airway is patent. So moving on to B for breathing. So it's exactly the same marking criteria as in the adult OSCE. So first off, you are going to observe and record the respiratory rate for 1 minute. And after that 1 minute, you are going to be verbalising what that respiratory rate is. You are also going to verbalise the depth. So was it shallow? Was it deep? Was it just a normal depth? You're also going to verbalise the pattern. And the rhythm. So was it regular or irregular? And then during that 1 minute observation, you're also going to observe for any visual signs of respiratory distress. So just confirming if there were any or if there weren't any present. So you want to confirm that there was, no use of accessory muscles, that the patient wasn't cynosed, no seesaw breathing. You want to make sure and verbalise whether there was equal air entry in the chest. You don't have to listen with a stethoscope. So you can just gently place your hand on the chest, or just visualize and say that you could see that both sides of the chest were rising equally. You also want to verbalize whether you heard any respiratory noises, so any audible sounds, wheeze, stridor, secretions, rattle, coughing. And you must do that full assessment. You must verbalize each component of that, otherwise it is a critical fail. The most common thing that is forgotten to be verbalized is the depth and rhythm pattern of breathing. Then you're on to circulation. Again, exactly the same as the adult marking criteria. So you're going to feel for manual pulse for 1 minute. You are going to feel, obviously after your 1 minute, you are then going to verbalise the results. You're going to comment whether that pulse, the strength of that pulse, so was that a weak pulse or a strong pulse, bounding pulse, maybe in sepsis. And you are going to comment on the rhythm. So was it regular or irregular? You're going to record the electronic blood pressure on your child as well, making sure the heart is at arm level. And then you need to go on and complete your capillary refill time. And in a child, you might just do this gently on the chest, because they peripherally can be a little bit more difficult to assess that. So you want a central capillary refill time. So you're going to press gently for 5 seconds, and then you're looking for return perfusion in 2 seconds. And you also need to verbalise on the pallor and perfusion of the child. So were they warm to touch, cool? Are they pink and perfused? Are they pale? Are they grey, clammy, cyanosed? Hopefully not. So you need to verbalise and complete all those parts of circulation. On to disability, so conscious level of your child. So again, using ACVU, you're going to, you don't need to do a full GCS unless your child is not alert, in which case you would move on to do your full GCS. You can check the pupils, make sure they're equal and reacting to light, and you need to assess pain levels in this station as well. So you might have an older child who's maybe 15 potentially, in which case you can do a 0 to 10 pain scale, so 0 being no pain, 10 being the worst pain they've ever had. And for younger children, you might be using visual pain tools such as faces. Commonly you're asked to do like Wong-Baker faces and pain scale. You need to ask if they have passed urine. And again, if it's a younger child, you want to confirm that with the parent, or maybe ask if they've had a wet nappy or when the last wet nappy change was. And you need to get a most recent blood glucose. So again, you can ask the examiner for this information. So what is the most recent blood glucose of the child? So anything between 4 to 7 pre-meal and 4 to 9 post-meal. And then we're on to exposure. So you're going to take the child's temperature, and then you want to review the mannequin and ask the parent if there's any injuries, rashes, bleeds, bruises, kind of top to toe, any swelling. So you're going to document that down for E. And then finally, and really importantly, it always gets forgotten in E, is you need to obtain a full medical history for your child. So on your scenario briefing, you'll have some past medical history. So it can just be easy, really, is reading that out to the parent and child and confirming if there's anything else which you need to know, which isn't documented down on the past medical history. And it's about identifying patients that are at risk groups for things such as sepsis, so diabetes, immunosuppressed, neuromuscular conditions, heart conditions, things such as that. So don't forget your exposure, doing your medical history. And then once you've done your A2 assessment, you want to move on to documentation of your PEWS. I'm going to do some separate videos on the PEWS and look at those in more detail. You'll need to really carefully document and plot your observations onto the PEWS chart. You'll need to calculate your score, and then on the PEWS chart, you will need to verbalise your actions. So what level of escalation to who, and how often you're going to come back and monitor the observations on that child. This is really an essential step to pass, so really important you're familiar with your PEWS charts. So from September the 9th, 2024, they are going over to the new NH England news charts. So there's 4 different charts, and you can get those from the supporting documents, or you can just Google NHS England PEWS charts, and you can get all 4 copies of PEWS charts there. So 4 different PEWS charts for 4 different ages, so 0 to 11 months, 1 to 4 years, 5 to 12 years, and over 12 years. And I'm going to look at those in more detail in another video, like I said, but download those and familiarise yourself with the PEWS charts, because there's a lot to take in the exam situation. And then you'll need to go on to your holistic assessment of your child, and you won't have a huge amount of time to do a really in-depth assessment. So it's important to pick out key areas from your scenario briefing and know key assessment priorities for those 2 conditions, so assessment and post-op tonsillectomy bleed. So like I said, you'll need to kind of pick up on key areas. So listen to your child, listen to your parent actor, identify any areas for health education. So maybe one of the parents smokes, for example, and that child's been a bit of asthma. That could be an area that you could approach sensitively with the adult. Be compassionate. Obviously, don't dismiss any concerns or problems. In terms of your holistic assessment, like I said, you won't have a huge amount of information. So physical, focus that in on the primary reason that child has come into hospital. So for example, your asthma, you might want to find out, how often the asthma attacks occurring, is there anything triggering them, are they managing with their inhalers at home, finding out a little bit more information about how they're managing that asthma on a day-to-day basis. Psychosocial, again, just checking in on if there's any anxiety, if the child or the parent feeling emotionally low or distressed, thinking about the social setup within that household as well, and whether you feel there's any risk to the child potentially. Spiritually, just really important to check with your parent and child that they haven't got any spiritual and cultural beliefs and needs whilst in hospital, which you can support with. And obviously sexual, in terms of your child, thinking about, who does that child live with in the home, who is part of that family, what is the support network as well for them. So remember, read your assessment information carefully, identify and acknowledge your issues. Don't forget to ask questions to find out more information. Remember your communication skills, especially that child-centred approach to communication. Don't forget about the child, especially as you've just got a mannequin, a bit of plastic in the bed. Escalate and refer to other professionals as appropriate, but only with your child and parents' consent. The GCS assessment, this, you would only need to complete the GCS if the child was not alert. So if they're responding to voice, pain or unresponsive, and quite unlikely in your OSCE. But just be aware of it. You'll need to do that full GCS, including eye response, verb response, motor response, pupil reaction to light, and size, and obviously limb power and strength. And like I said, you may very often be asked to do a pain assessment, and you might be asked to do the wrong basis pain rating scale. So familiarise yourself with that pain rating scale, and be sure you can explain that and get that information across to the child so they understand what that means and what face represents their level of pain. So that it comes very often hand in hand with your assessment station. You might specifically be asked to do that in your briefing station. So my top tips, my top tips is, remember your child-centred approach, family-centred approach, and that communication. Make sure you do all your ID and allergy checks with your child, but also confirm with your adult. Always make sure you get valid consent, explaining what you are planning to do to the child and also to the adult, and make sure you get consent before you move on. Make sure you're accurately recording your patient details on your PEWS chart, and your observations on that PEWS chart, really important. Complete your A3 assessment in that systematic order and verbalise every part. Make sure your nursing assessment is related to the child scenario, so concentrate on those main nursing needs and build that rapport, like I said, with your child and your family. Listen attentively, show compassion, and answer any questions and address those issues straight away. Practice to time as much as possible, absolutely key to getting this all completed within your 20 minutes. So I hope that's helpful. Been supporting a few child nurses now with one-to-one tutoring. So if you're wanting some support with your Child OSCE, drop me an email, hannah.lames@outlook.com. We've got 2 API scenarios, the asthma and tonsillectomy as well. Got all the professional values and evidence-based scenarios as well. Can do a mock Child OSCE, and going to be putting out some more child content as well.